really happy. Our chapter is dedicated to creating valuable opportunities and meaningful learning experiences for aspiring neurosurgeons like ourselves across the Kingdom of Saudi Arabia and beyond, supporting growth on a personal, educational, and career level. So make sure to follow our social media platforms to stay updated with our latest events and upcoming activities. We are very excited for today's webinar. Our session is going to focus on pituitary tumors, which is among the most commonly encountered pathologies in neurosurgical practice. So understanding the anatomy, physiology, and clinical relevance is essential to providing the best patient care. We are honored to be joined by one of the most iconic women in the fascinating field of neurosurgery, Dr. Ashwag Alqurashi. Dr. Ashwag is a neurosurgery consultant specialized in skull-base and endoscopic surgery in King Saud University Medical City in Riyadh, Saudi Arabia. She is the first female skull-base surgeon in the kingdom. In addition to that, she serves as the head of the SANS Academy and the treasurer of the Saudi Association of Neurological Surgery. Before we welcome our speaker, we encourage you to approach this session with an open mind. So please feel free to submit your questions at any time in the chat, and we will make sure to address them, inshallah, later on towards the Q&A segment of this session. So without any further delay, let's begin. It's my pleasure to welcome Dr. Ashwag. The floor is yours.
Thank you, Dr. Bayam, and thanks for the SANS medical chapter for organizing of this educational webinar. You are doing a great job as a group in educating the student in neurosurgery. So our today lecture will be about pituitary tumors. Will be a comprehensive review. By the end of the lecture, inshallah, you will be able to understand the anatomy of the pituitary gland and the hormone physiological hormonal secretion of the pituitary gland, as well as we'll talk about the pituitary tumors, clinical presentation, red flags, and the management. So to start with the anatomy, the pituitary gland is located in the sella turcica. You can see here, this is a lateral view of the illustration of the brain. Here is the sella. It's located in the bone of the sphenoid. This inside the sphenoid bone, and this is the pituitary gland. The pituitary gland is connected to the hypothalamus through the pituitary stalk, which is located here. Superior to the pituitary gland, you will find the optic chiasm. Inferior to it, it's the sphenoid bone. Here is the coronal view. You can see here the pituitary gland. This is the stalk, connect the pituitary gland to the hypothalamus. This is the chiasm. It's located behind the pituitary, stalk. And in each side, you can find the cavernous sinus in each side of the pituitary gland. This anatomy is very important to be understood. So during the management of the pituitary adenoma surgically, you will be able to approach all of this area and to identify the normal anatomy as well. So for the pituitary gland, this is the same view, lateral. This is the pituitary gland. Pituitary stalk connected to the hypothalamus, superior to the pituitary gland, you will find the chiasm. So the pituitary gland have two components, the anterior lobe and posterior lobe. Anterior lobe is originate from the adenohypophyseus, and it's responsible about secreting the hormones, while the posterior lobe is from neurohypophyseus, and it's responsible about the storage and releasing of the hormone. This is also same view for the pituitary gland. You can see here the vascularity of the pituitary gland. We have two main supply, which is a superior hypophyseal, located here superior, and the other is the inferior hypophyseal. Both of them are originating from the branches from the internal carotid artery. The superior hypophyseal will make like a vascular loop around the pituitary stalk and also the anterior part of the anterior of the pituitary gland, and it's responsible about the portal circulation, which is regulating the secretion of the hormone, while the inferior hypophyseal is supplying the posterior pituitary, and it's responsible about releasing of these hormones. Here again, another same view. You are looking for the anterior pituitary in this side and posterior pituitary for this side. we will see the secretion, which the anterior pituitary gland is responsible about secreting most of the hormones, like the TSH, the thyroid stimulating hormone, which target the thyroid gland to control the secretion of the thyroid hormone, the ACTH, which is target the adrenal cortex to secrete the cortisol, the prolactin target the mammillary gland for lactation, growth hormone target the tissue, bones and liver for growth and metabolism, and the LH and FSH, which is the gonadotropin, target the gonads for reproduction. While the hormones secreting from the posterior pituitary gland, we have two main hormones, ADH and oxytocin. The ADH is the vasopressin, which is controlling the amount of the water and the sodium in the body by acting on the water reabsorption in the kidney, while the oxytocin is secreting to contract the uterine smooth muscle, as well as the mammillary gland to eject the milk. This is a summary for all the hormones. Most of them from the anterior and two of them from the posterior. And this is the things that we mentioned. So now we'll start with the pituitary adenomas, which is a benign tumor that originate from the pituitary gland. So for the epidemiology, the distribution from the US in the location of the silla. We'll have 18% of the brain tumor are located in the silla. The pituitary adenoma here, it's containing of the 17% of all the primary brain tumors. And if you can see here by the age, most of the, or the mean age of the pituitary adenoma, it's around 40. It's very rare to come in children below 14, and it's less common in the younger than 40. This also in the US. Here you can see all the epidemiology in Saudi Arabia that published. The last one was in 2016. We have a different distribution for the pituitary adenoma. We have a younger patient, most of our patients between 25 and 35. Here in one of the big centers in Saudi Arabia, they found that most of the cases are microadenoma. And this because after the era of the MRI, we have a previous older statistics showing that the macroadenoma are more common. This was because before the era of the MRI. So after the MRI, now we have a lot of incidentally finding microadenoma. That's why the number is increased. For the type, before we have more of non-functioning pituitary adenoma, and now in the latest statistic we have most of them are prolactinoma. This playing a role maybe because the main group that published this it was from the endocrinology. So they have the most of the prolactinoma cases more than the surgical cases. For the prolactinoma, it's more common in female compared to the male, and it's in microadenoma more than the macroadenoma. So in summary, it's the most common tumor, third most common tumor after the meningioma and diffuse glioma. Female ratio are slightly higher, rare in children. The percentage, it's almost 80 cases per 100,000, and 50% of them are macroadenoma. We can classify the pituitary adenoma by either size or functional. By size, we have three types. As you can see, here is the coronal MRI, this T1 with contrast. It's zoomed in on the silla part. So this is the pituitary gland in the red, and here is the chiasm, and this is the pituitary stalk. You can see here there is an area in the right side of the pituitary gland. It's taking less enhancement compared to the normal pituitary gland. This is the adenoma. So size of this lesion is less than 1 centimeter, so we call it microadenoma. While here in this area, it's same coronal view. You can see this, the white or the contrast enhancing tissue. This is the normal pituitary gland. Here is the chiasm. So this area is the pituitary adenoma. This is more than 1 centimeter, so we call it macroadenoma. While if it is like this, more than 4 centimeter, it is a giant adenoma. So the other way to classify it is by the functionality. We have non-functioning pituitary adenoma and functioning. Non-functioning, either it's originated from the silent gonadotrope or from the other non-secreting cells. While the functioning, we have four more common, which is the prolactinoma is the most common one. It's having a high prolactin level. The acromegaly, when we have a high secreting growth hormone, Cushing disease, when you have ACTH secreting adenoma, or rarely the TSH or FSH secreting pituitary adenoma. We will go through one by one and the clinical presentation of each one. So in the last WHO classification for the brain tumors, they changed the name of the pituitary adenoma. Now they are calling it a pituitary neuroendocrine tumor. So why I'm mentioning this? Because there is a new way to classify the pituitary adenoma by using the lineage-based classification. And here I will go through it briefly. The neuroendocrine cells, we have two main categories, which is epithelial and paraganglion. The pituitary adenoma or pituitary neuroendocrine cells, it's under the epithelial cells. We have a three cell lineage for the pituitary adenoma. For example, the somatotroph, if the tumor is originated from the somatotroph, this is under the BIT1 lineage. And so this we can classify it as a BIT1 lineage, and this is purely a pathological classification. They use a specific marker. And it's not depend on the hormonal secretion, it's depend on the origin of the tumor. So for clinical presentation of the pituitary adenoma, it's either depend on the tumor size or the functional status. For the tumor size, as we mentioned, the microadenoma is less than 1 centimeter, and usually it is incidentally found in MRI. Patient will be asymptomatic unless it is actively secreting hormone. For the pituitary macroadenoma, it's present usually with the mass effect or excess of hormonal secretion. The most common symptoms from the mass effect is the headache. It's almost 60% of the patient will present with the headache, which is unspecific presentation. The visual impairment, most of the cases with the large tumor will present with the visual impairment, at least 50% of them. Here you can see this is the visual field. Number 4 is the chiasm, where usually the pituitary adenoma compress on the chiasm, so the patient will have a classical bitemporal hemianopia. And if the lesion is compressing on one optic nerve, which is rarely, but if it is happen and compress on one side more than the other side, patient will have monoocular loss. The other presentation from the mass effect is the cranial nerve palsy secondary to the invasion to the cavernous sinus. Here you can see this illustration of the cavernous sinus, same picture we see in the beginning. This is the pituitary gland here, and the cavernous sinus is located from each side of the pituitary gland. So the cavernous sinus normally containing the internal carotid artery in the middle with the abducent nerve. In the lateral wall, we'll have the oculomotor, trochlear, V1 and V2. So if the lesion is extended into the cavernous sinus, most likely it will present with the diplopia secondary to the abducent nerve palsy. If it is extended more to the lateral wall, patient may present with any of this cranial nerve palsy, like the extraocular movement restriction or diplopia. Here, this is the MRI view. You can see this is the area of the pituitary gland, and in each side, this is a left side, cavernous sinus. This is a normal picture. Here, if the lesion is invading the cavernous sinus, we are using a classification called Nospix classification. I will go briefly on it to understand it. So in this lesion, you can see this is a normal pituitary gland. This is the pituitary stalk, and this is the chiasm. Here is the pituitary adenoma. This is the cavernous sinus in the left side, the ICA here, and if we draw a line like here, if we draw a line medial to the ICA and another line lateral to the ICA, another line in the middle, so each one will have a different grade. like in this picture, it didn't went beyond the medial wall, so this is grade 0. It didn't invade the cavernous sinus. So in the next picture, it is invading the medial wall, but didn't cross beyond the half of the internal carotid artery. So this is grade 1. If it went beyond it, but not lateral to the internal carotid artery, so this will be like in this picture, grade 2. And if it went more further lateral to this line, will be grade 3. And if it is encasing, like in this picture, the carotid artery completely, this is a grade 4. So the other symptoms, it's from the mass effect, is the hormonal deficiency. Each hormone will cause a specific presentation. Like if a patient presented with the deficiency of the gonadotrope, the woman will have amenorrhea, the men will have erectile dysfunction, the TSH will have patient a symptom of the hypothyroidism. For the growth hormone deficiency in adult, patient will have fatigue and weight loss, as well as in the ACTH deficiency will have nausea, vomiting, abdominal pain, and hypotension. The other presentation other than the mass effect, if the patient presented with the symptom secondary to the hormonal excess, so we'll call it as a functional pituitary adenoma. We have a prolactinoma, excess secretion of the prolactin, the growth hormone secretion excess will give us acromegaly, the SATH adenoma will give us a picture of Cushing disease, and TSH adenoma will give us a hypothyroidism. So for the workup, if patient presented with the query symptom related to the pituitary adenoma, we have to have a full medical history and examination. Examination including evaluation of the optic pathway by doing an ophthalmology evaluation for the visual field. Also, it's need a full hormonal profile and evaluation by the endocrinology. The hormonal profile is including the prolactin, insulin growth factor, growth hormone, cortisol, ACTH, TSH, the thyroid function, and LH and FSH, as well as the image including the MRI. You can see here in the first, this is a normal pituitary gland. This is the sagittal view. This is the pituitary stalk here, and this is the gland. The posterior part is hyper intense in this image, which representing the posterior lobe of the pituitary gland, and the anterior part is hypo intense. Here is the coronal view for the same picture. For the MRI for the pituitary adenoma, we need to do a specific protocol. We call it MRI pituitary protocol, because they are give the contrast and take the image early and late. So like in this picture, you can see when they take the earlier image, it doesn't show a difference between the lesion and the contrast, while here the late image, you can see the pituitary gland taking a contrast more, so it will appear more brighter compared to the lesion. So here there is a microadenoma. You can see it in this area. It's taking less contrast compared to the normal pituitary gland. And the other image that we need to do is a CT paranasal sinus, and usually we are doing it if we are planning to do a surgical intervention for these cases. So we'll start for the each one of the functioning pituitary adenoma. We have a 4 type. We'll talk about the most common 3 types, starting with the prolactinoma. The prolactinoma is a pituitary adenoma that is secreting prolactin, so it will suppress the gonadotrope. A patient will have infertility, decrease in libido, and osteoporosis. The woman will present with the amenorrhea, galactorrhea. The men will present with the erectile dysfunction and gynecomastia. You can see in this image, here is the sagittal and coronal view for the lesion. It's a macroadenoma or giant because it's more than a 4 centimeter almost. So this, when they did a hormonal profile, the prolactin level was very high, so it is a prolactinoma. In this lesion, here in this image, this is a young female presented with the amenorrhea and galactorrhea, and also the prolactin level was high, and the image showed that there is a lesion in the right side of the pituitary gland, and this lesion is a prolactinoma. So the normal prolactin level is from 0 to 20 nanogram. It's equal to 500 international unit. So for prolactinoma, patient will present with a prolactin level more than 200 nanogram. There is sometime in the giant or a large pituitary adenoma, it will cause something called stalk effect, which means that it's compressing in the pituitary stalk, so it will hold or suppress the dopamine effect, which is regulating the secreting of the prolactin. So we'll have a moderate elevation of the prolactin, but it didn't reach to the level of the prolactinoma, so it will be less than 200. And if it is a giant pituitary adenoma that causing a significant compression, and it is prolactinoma, but sometimes we have a hook effect, which means the lab will show us a false normal result for prolactin level. At that time, if you are still suspecting it's prolactinoma, we will order for a dilution of the sample, so they will get a true prolactin level, and sometimes it's masking by the Hawk effect. The prolactinoma is a medical management, usually is the first option for it. We are using a dopamine agonist, most likely the carbogaline. It's effective in 90% of the cases to normalize the prolactin and decrease the size of the lesion. And after 1 year of completion of the treatment, you can stop the treatment or if there is no further lesion or growing of the lesion. When we do the surgery for this type of cases, if we have a significant mass effect with the acute visual deterioration, so we need to do a surgery to decompress the mass and to release the pressure. The second thing, that if the medical therapy is not working, that means the follow-up imaging, we are seeing the lesion, it's getting larger, or if the patient is having a side effect from the medication, like postural hypotension or cardiac abnormality, or mood changes, so he's not tolerating the treatment. At that time, we are doing a surgical resection to resect the lesion. The radiation therapy, usually for the cases that failed a medical and surgical treatment, so the radiation therapy could be used in specific cases. So the second is growth hormone adenoma. The growth hormone adenoma will give us a picture of the acromegaly. Usually the patient will present complaining of the bigger size of the shoes, or the change the size of the ring, or changing in the features of the face. Will have bigger lips, or bigger tongue and hands. So these features is representing features of the acromegaly. So for this patient, usually we need to do a workup, including systemic workup, because the secretion of the growth hormone will cause a thickness for every organ, including the heart. A patient will have a cardiomyopathy. Also, regarding the intestine, patient may have multiple colonic polyps, or it's cause an thickness of the skin and throat, so will present with the obstructive sleep apnea, or thickening in the tissue. Patient may present with the carpal tunnel syndrome. So all of this comorbidity, it's secondary to the excess secretion of the growth hormone. So for these type of cases, it's need a workup. Start with the screening by sending the hormones, including insulin-like growth factor. For this, if it is increased or the random growth hormone is increased, so at that time we'll do oral glucose tolerating test. If it is the growth hormone is still high after the oral glucose tolerating test, so this is a diagnosis for the acromegaly. The management for the acromegaly is the surgery, because we are aiming to resect the total lesion, and the aim also to decrease the growth hormone and normalize the insulin-like growth factor. And this because we want to avoid the comorbidity that happen from the increasing of the growth hormone. Usually the surgery is good in controlling the disease, in microadenoma reaching up to 90%, in the macroadenoma up to 60%. And the second line of treatment is the medical therapy. Sometimes we are using it in after the surgery if still the growth hormone is still not controlled and not normalized as an adjunct to the surgery. Usually it's using the endocrinologist will use the somatostatin analog, or the second option is dopamine agonist. The radiation therapy also is for the cases that failed medical and surgical treatment. So the third one is the ACTH adenoma. For this patient will presented with the Cushing features. Like in this picture, you can see the patient is having a moon face, is having a dark facial hair, especially in the woman, and the increase in the fat pad in the supraclavicular area. Patient may presented with osteoporosis, cardiac hypertrophy, and the purple stria in the abdomen, or amenorrhea in the for the woman. This case is a coronal view for the 14 years old male presented with the same picture with the moon face, and the STH level was high. So you can see here, you can see there is a microadenoma in the left side of the pituitary gland, and this is presenting a high excess of the ACTH. For the workup, we do a screening test first, starting with the 24-hour urine free cortisol to level the cortisol level, and also the cortisol in the salivary during night. Also, we can do a test for short dose or low dose dexamethasone suppression test. So if it's all show a positive or high result of the cortisol, so at that time we are calling it a Cushing syndrome, and we have to do further workup to see where is the origin that's secreting the excess level of the ACTH. So we do a high dose dexamethasone suppression test. We give a high dose of the dexamethasone, 8 milligram, and then we do a level of the ACTH. If this level suppressed, so we know that it's suppressed because it is originating from the pituitary gland. So at that time, we're calling it Cushing disease, like in this in our example for this patient. And for this, we do MRI pituitary gland to confirm the diagnosis. If the ACTH didn't suppress after giving a high dose of the dexamethasone, so it's either from the adrenal or from ectopic origin. So we do CT abdomen and chest and adrenal CT for adrenal gland. If it is equivalent and it is not conclusive, at that time we do a petrosal venous sampling, or we do a corticosteroid releasing hormone stimulation test by giving it intravenous and then testing the ACTH. So if confirmed that it is a Cushing disease and the origin of the excess ACTH hormone is from pituitary adenoma, at that time we do a management. The main management is by doing a surgery and resecting the tumor. The cure rate is almost 70 to 90%. We can use a medical therapy if the surgery didn't normalize the level of the ACTH, so we can use it as a bridge till we reach a normal ACTH level, or for the cases that have a persistent or recurrence. We can use either the same medication that we used for the growth hormone, like a somatostatin analog, or for the prolactinoma cases, like a dopamine agonist. Other choices to give adrenal steroidogenesis inhibitor or the glucocorticoid receptor antagonist, and usually this is managed by the endocrinologist. In case that failed surgical and medical treatment and still patient is having excess hormone of the ACTH, that time we need to do a bilateral adrenalectomy by doing resection, surgical resection for both adrenal gland. The side effect of this, that some cases, almost 25 to 40% after resecting the both adrenal gland, they will have enlargement of the pituitary adenoma in the image, and this we are calling it a Nelson syndrome. The radiation therapy, if all the other modality of management failed, that time we give a radiation therapy for the adenoma. So shifting to the case, this is a 40 years old male present to the AR with the sudden headache, vomiting, and diplopia. You can see here in the image, this T1 without contrast. The last one is the T1 with contrast. You can see there is this is the normal pituitary tissue. It's taking contrast compared to the T1 without contrast. And there is a cyst-like, you can see it in all images, and this representing a bleeding or hemorrhage inside the pituitary lesion. So this case, because of the acute presentation, so it is a pituitary apoplexy. So the pituitary apoplexy, this is an medical emergency case. Patient may present with a sudden hemorrhage, infarction of the pituitary gland, usually in the patient having already pituitary adenoma. The red flag for this, its patient will present with a sudden severe headache, acute rapid visual loss, diplopia, or hypotension secondary to the ACTH deficiency, may present with the vomiting or decreased level of consciousness. So if any of this presentation, you need to deal with the case as an urgent case. We need to send a full hormonal profile to check the hormonal deficiency and to proceed with the doing of the image, including the MRI pituitary, to check for the hemorrhage. And the management of the pituitary apoplexy starts with the high dose of dexamethasone to prevent adrenal crisis. We need to normalize the electrolyte to give fluid. As I said, to do the image to find the lesion and the source. It's need close monitoring for the visual field and for the conscious level. In the cases that presented with the deterioration, the diplopia or visual field defect, the surgical intervention is needed to decompress the optic chiasm, and usually it's need to be done within the first 7 days from the bleeding. So we finished from the pituitary adenoma and all the differential and all the different subtype of the adenoma. And here is the list for the differential diagnosis for the lesion that presenting and may mimic the pituitary adenoma. Just for you to see that there is a long list. You can see in the right side, I put 2 images. The first one, this is a Rathke cyst, and the second one is a craniopharyngioma. It's totally a different category than pituitary adenoma and had a different approach to it. We have another lesion like glioma, mainly in the children, could present mets, lipoma, lymphoma, and other differential diagnoses. Today we are focusing on the only pituitary adenoma. So for the management of the pituitary adenoma, as we mentioned during presenting the subtype, the surgical treatment, this is the main treatment for the non-functioning pituitary adenoma presenting with the mass effect, especially with the effect on the vision, or if there is any evidence of growing of the lesion on the follow-up MRI. For the functioning pituitary adenoma, the surgical treatment is a first line of treatment in the growth hormone secreting adenoma, which is the acromegaly, and also for the Cushing disease. The medical treatment is the first line of treatment in prolactinoma and can use as a supportive treatment for the growth hormone or STH if the secreting hormone is still the level of the hormone is still high. And the medical treatment also can use a replacement for the hormonal deficiency if in non-functioning pituitary adenoma. Radiation therapy, it's another tool that you can use it in the cases that failed medical and surgical treatment. We have here 2 examples. The first one is a non-functioning pituitary adenoma causing a mass effect in the chiasm. Usually the chiasm, it's locating here in the superior part. We cannot appreciate it here because of the mass effect. So this patient needed a surgical intervention. This patient is having a prolactinoma. There is a mass effect on the chiasm, but there is no acute visual deterioration. So started on the medical treatment, and it's get better with the medical management. So this is an example for the OR cases for the non-functioning pituitary adenoma. Here, this is the setup for the cases, either to be done by endoscopic approaches or open approaches. Usually, we are doing it by endoscopic approaches. more than the open approaches, specific indication for the open. So for the endoscopic approaches, either to use the endoscope or microscope transnasally. So here is our setup for the endoscopic transnasal approaches. This is an example for a case of non-functioning pituitary adenoma. Here is the view by the endoscope. We are inside the sphenoid. We open the silla, and this is the dura. Now we are opening the dura. You can see the tumor is bulging out. You can see it here in the image. It is descending in the sphenoid sinus. And here I want to show you how the tumor looks like intraoperative. So this is the tumor. It's very suckable, yellowish, and this is the pituitary adenoma. After doing a resection, you can see this view where this is the diaphragma cilia descend down, which means the compression on the chiasm, it's released. So for the follow-up for these cases, it's usually an excellent prognosis, especially for non-functioning pituitary adenoma that presented early without a severe effect on the vision, or for the prolactinoma also has a good prognosis. For the other functioning pituitary adenoma, it's need to be managed early before it's causing comorbidity on the other organ. The long-term follow-up, it's need a regular hormonal monitoring, regular follow-up with the endocrinology, regular follow-up with the ophthalmology for the visual field examination, also follow-up with the MRI, and also this all it's need a multidisciplinary care. And thank you. If you have any question, I can answer it.
الله يعطيك العافية دكتورة. Thank you so much for sharing your valuable expertise and for the thorough yet very concise explanation. So we have a few questions in the chat box. The first question is, why was the shift towards molecular diagnosis of pituitary neuroendocrine tumors made despite the fact that a specific lineage marker may be identified, yet the tumor may still be non-functional? How is this clinically or surgically?
Still, this is a new classification. Still, till now, it's not. We are not using it. At least in our center, because it's still need specific markers. But for this, because they want to classify it not only on the hormonal secretion, but they want to do like a something with the markers. So we have now many markers that can be used to identify the origin. Like as I mentioned, that there is still 3 lineage. For example, for the somatostatin, if the patient presented with the somatostatin and which is secreting the growth hormone, so this is will be a growth hormone secreting adenoma. But if it is not secreting the growth hormone and patient having deficiency, and still the origin is somatostatin, will not calling it a growth hormone secreting adenoma. So depend on the cell line will give you the more specific subtype. So this is the main cause, and because sometimes there is a multi-origin for the tumor, you can find a multi-cells that originating, or even if you need read the report of the pathology, you can find it's originating from the multi-cells, but still it's not functioning. So this is just to be more specific, and for sure in the future when we have this more classification, I believe that we'll find that one cell line will be more aggressive than the other, or the prognosis of one will be better than the other. This will give us information in the future.
الله يعطيك العافية. Thank you, doctor. Someone asked, what radiological features predict the failure of transsphenoidal surgery?
The failure of transsphenoidal surgery actually first for the patient presenting with the acute visual deterioration, usually we are doing a surgery to decompress. So we need to reach a decompression, which means to have a space between the tumor and the optic chiasm. So if we reach this, even if we didn't reach a gross total resection, but at least we decompress the main bulk and there is a space between the chiasm and the tumor, this is a success. Despite of the residual, this we can follow it later or do another stage when it's descend down. But if it is you do a surgery and still there is a bulk of the tumor that compressing on the chiasm. So at that time, I will not call it a failure, but I will say that it's need a second stage earlier than the other patient. Sometimes there is a lesion that going inside the cavernous sinus, and you cannot resect that part because the side effect or the risk from the surgery it's high. So you can leave some part in the critical area, but the chiasm it's need to be away or decompressed at least from the tumor capsule.
Awesome. We have another question. What is the role of the KNOSP grade 3 and 4 invasion in choosing the approach?
Yeah, there is some extended approaches, like we can go by endoscopic, doing a transcavernous sinus approach. So if we are knowing from the beginning that this lesion it's mainly inside the cavernous sinus, so we plan our approach not to go a classic transsphenoidal approach. We will go transcavernous sinus approach, which means that we will drill the bone anterior to in the anterior wall of the cavernous sinus. We will open the dura, the anterior wall of the cavernous sinus, to approach the lesion in that area. Usually, we don't do this in the non-functioning adenoma because of the risk, as I mentioned, but in the patient functioning, like in the growth hormone secreting, and you need to reach a cure by resecting the tumor completely. So we do this extensive approach.
Okay, amazing. Another question is, should a surgeon attempt a gross total resection by opening the medial wall of the cavernous sinus, or is subtotal resection and radiosurgery the only responsible standard of care in KNOSP grade 3 and 4 tumors?
Yeah, sometimes the lesion which is invading when it's invaded the cavernous sinus, it will make like a hole in the medial wall of the cavernous sinus, and when you are resecting the lesion, you can go through it and resect it safely. But because, as I mentioned in the anatomy, the ICA and the sixth nerve, it is inside the cavernous sinus. So sometimes there is a risk of injury of the internal carotid artery, unless someone is expert in doing this type of approach. Mini. So you can resect the lesion from the internal from the cavernous sinus if you are sure that you know how to do it safely. For the non-functioning adenoma, no need to go to into the cavernous sinus because the lesion it's non-functioning. So doing a decompression is enough in these cases, and leaving the part inside the cavernous sinus. If it is growing, then patient can go for radiation therapy. For functioning pituitary adenoma that need to reach a cure, yes, you can go and resect the tumor from the cavernous sinus if you know how to do this type of approaches.
Thank you so much, Doctor. Mashallah, we have so many questions, so we're going to try to keep this short in respect of your time. Another last question is, what is the best way to prevent CSF leak, a fat flap or a turbinate flaps, or both?
For the CSF leak, usually in the pituitary adenoma, when you have the diaphragm descend nicely and you don't have a CSF intraoperative, you can use a surgical or a graft over the opening if the cavity is small. But if it is big and empty, you can use a fat followed by a graft. For the extensive cases, when you have a CSF leak or the macroadenoma that you do transsphenoidal approach and you drill part of the sphenoid sinus, in this approach, it's better to use a flap. So our usual protocol, we put layer of surgicel and fat inside the cavity, and then we use fascia lata over it, and the last layer is the nasoseptal flap. This is the best way to prevent the CSF leak. There's multi ways, but doing a multi-layer is usually recommended, especially if there is a CSF leak intraoperative.
Allah يعطيك العافية دكتورة. Thank you so much. We don't want to take more of your time, so inshallah, whoever has a question, we will be sharing a Google Forms link with you. Just fill it in, and with your question, and we will make sure to share them with the doctor to share her expertise. Thank you so much again, Dr. Ashwag, for your time, and we really appreciate your lovely presentation.
Thank you. يعطيكم العافية جميعا. I hope it was very comprehensive and short and focused in the same time.
Alhamdulillah. Allah يعطيك ألف عافية. Thank you all for
Thank
coming.
you.
See you inshallah in another webinar. Have a
Thank
great
you.
rest of your night. Bye bye.
See you. Bye.